Overdenture. With increasing stress on preventive prosthodontics, the use of overdentures has reached a point where it is now a feasible alternative to most treatment plan outlines in the construction of a prosthesis for patients with remaining teeth. There are different types of overdentures that are indicated for different conditions, with many advantages and disadvantages. Such a treatment is usually associated with one of the several types of attachments. Definition: a removable partial or complete denture that covers and rests on one or more remaining natural teeth, roots, and or dental implants. The important goals of overdenture: first, maintains teeth as part of the residual ridge to increase support, retention, occlusal load withstanding. Second, decrease the rate of bone resorption. Third, retaining the proprioception. Indication of overdenture. The indications of overdenture: first, few remaining teeth unsuitable for fixed or removable partial dentures. Second, remaining teeth present with unhealthy periodontal condition. Third, patient with class 2 or class 3 angles classification. 4. The construction of overdenture is an alternative line of treatment to single denture opposing few natural. 5. Patients presenting congenital defects as cleft palate, microdontia, amelogenesis, or dentogenesis imperfecta. Patient presenting abnormal jaw size, large maxillary or mandibular bone defect, and congenitally missing teeth. While the contraindications for overdenture: first, poor oral hygiene. Second, inter-arch space inadequate to accept the denture and the abutments. Third, mentally and or physically handicapped. Fourth, periodontally involved remaining teeth. Fifth, non-restorable or mobile abutments. Sixth, cost and time consideration. The of overdenture prosthesis: first, preserving the remaining residual ridge by decreasing the rate of bone resorption. Second, preservation of the abutments as part of the residual ridge to gain support. Third, preserving the response of proprioceptive exists in the periodontal membrane of the abutment tooth. Fourth, the modified teeth provide a definite vertical stop for the denture base. Fifth, horizontal and torque force are minimized. Sixth, stability and support are increased. 7. Patient acceptance and psychological benefit. 8. A simple approach to the problem patient. 9. Fewer post-insertion problems. 10. Convertibility and effective management. 11. Periodontal maintenance and provide retention through the attachments. The disadvantages of overdenture: first, caries susceptibility; second, periodontal disease of the retina; third, bony undercuts of the alveolar ridge are often found adjacent to retained teeth; fourth, overdenture construction is time-consuming and expensive procedure; fifth, encouragement of interocclusal disorders. The classification of overdenture: we can classify overdenture into tooth-supported and implant-supported overdenture. The tooth-supported can be classified into non-cupping, cupping, and attachments. The cupping can be classified into short and long type, while the attachments will include stud, bar, and magnets type. We start with tooth-supported. Tooth-supported, a complete or partial removable denture supported by tooth or retained roots to improve support, stability, tactile and proprioceptive sensation, reduce ridge resorption. The tooth-supported complete denture is also called overlay telescopes and biological denture. The classification of tooth-supported overdenture based on the method of abutment preparation. The tooth-supported, as we said, can be classified into non-cupping, cupping, and with attachments. The non-cupping abutment: here the coronal height of 2 to 3 millimeter and the convex or dome-shaped surface, and the tooth is endodontically treated and filled with amalgam or composite restoration on the top of it. The abutment with cupping preparation: a cupping is a cover for the exposed tooth surface, cast metal cupping with a dome-shaped surface and a chamfer finish line at the gingival mark. There are two types of cuppings. We have the short cast cupping and long cast cupping. The short cast cupping, 2 to 3 millimeter long, and endodontically therapy and cast cupping has post fitted to the canal. The long have 5 to 8 millimeter long abutment, and endodontic treatment is not a must. Conservative reduction need and a greater level of osseous support. While the abutments with attachment have most attachments are secured to the abutment by cast cupping and objective to improve retention of denture base, consisting of two parts, which is the male and female part. Abutments with telescopic crown. Abutment teeth are either vital or endodontically treated and contoured to tapered configuration. Tapered metal capping constructed and cemented over abutments. Denture constructed with metal crowns have veneered. The indicated for abutment with telescopic crown: first, unparalleled abutment; second, uneven space between abutments and useful for obturators. The advantage is increased retention and stability, and the disadvantage is the bulky crowns. Other classifications of overdenture, which is based on the type of the overdenture, into immediate, transitional, interrupt denture, and remote permanent denture. We start with immediate overdenture. The remaining teeth are reduced to accept the overdenture on the cast, and the dentures are constructed prior to the preparation of abutment teeth and is inserted after the preparation. The transitional or intermediate overdenture, here we used for patient in transition or preparation phase until permanent overdenture constructed, and the patient with old partial denture, and add new artificial teeth using self-cure acrylic. While the definite or remote overdenture is a conventional complete overdenture constructed over one or more abutment teeth, could be made entirely of acrylic resin or in conjunction with metal base. The uses of overdenture concept in other areas, like in case of congenital and acquired defects, the overdenture application can afford a very workable and relatively simple solution to patients with selected problems. The important benefit is that the technique is totally reversible. Partial overdenture, the use of an overlaid tooth that might otherwise be extracted to give posterior support to distal extension base or to provide anterior support for a large anterior supply on a partial denture, render obvious support advantage. The sequence of treatment of patients who need an overdenture: first we start with assessment, which include history, general and oral history, clinical examination like visual and digital examination, radiographic examination, and construction of the. Second is the treatment planning, include abutment selection, depend on periodontal status, minimum mobility, have acceptable bone support 5 to 7 millimeter above, and susceptible to periodontal. The endodontic consideration: the tooth must be treated endodontically to allow for sufficient reduction of clinical crown, ideally patient with single root teeth with only one canal, although multi-rooted teeth can also be used. The number and position of the abutment teeth in the arch. We can construct an overdenture for patients who have 2 teeth in each quadrant, like canine, or a first premolar and a second molar in each quadrant. The tripod is the next most favorable form, and 2 teeth in each arch, or we can construct it for patients with 1 tooth in 1 arch. Abutment preparation. First, simple tooth modification and reduction. The teeth are reshaped to eliminate undercuts and to reduce the vertical height. The indication: first, good oral hygiene with low caries index. Second, vital pulp. Third, severe abrasion of teeth. Fourth, sufficient Tooth reduction and cast cupping. Minimum reduction in the crown. Cast cupping are made after reducing the teeth to prevent the sensitivity or as caries control, and the indication by adequate bony support. good periodontal prognosis, and adequate interocclusal. The endodontic therapy and amalgam plug. The endodontic therapy reduce 1 to 2 mm gingival level to receive an amalgam type restoration, and the indication in case of low caries index, poor periodontal condition, normal coronal height to the teeth, and normal interocclusal distance. The endodontic therapy and cast cupping. Shallow dome shape with the margin slightly supragingival. The retention is gained from a short post that is placed within the root canal. The endodontic therapy with cast cupping utilizing some form of attachment. The abutments are prepared as in short cupping but with long intraradicular post to prevent root cupping dislodgement. 2 attachments are enough to retain a denture. Endodontic treated tooth with prefabricated retentive element. Simple and inexpensive way. Temporary fixation of overdenture. Spherical retentive element attached to a threaded post like Dalbo-Rotex system. Impressions for the abutment teeth. One stage technique with supported element. The abutment teeth without root cupping. The full arch impression is made as soon as the abutments are prepared. Root cupping without retentive elements. The impression is made after final cementation of the cupping. It covers all of the ridge except for any undercut areas near the abutment teeth. Then using zinc oxide eugenol paste or elastomer in the same manner as in the edentulous arch. One stage technique with existing retentive element. Zinc oxide eugenol paste or elastomers can be used. Pre-existing retentive element. Transfer mattress are set in place on the involved retentive elements and picked up in the impression. This is made it possible to incorporate retentive elements analogs in the working cast. The only difference in the construction of record bases for tooth-supported overdenture and conventional dentures is the incorporation of the metal bearing in the record base. The shape of the record base must correspond to that of the future overdenture. That's to say, it should not cover the facial marginal gingiva in the abutment region. The denture base designing criteria for designing the base: not unnecessary promote plaque accumulate, not mechanically traumatize the marginal gingival margin, and not disturb the performance of good oral hygiene, not interfere with normal function of the tongue, lips, and cheek, and not interfere with aesthetic or speech. The design of the denture is governed primarily by periodontal and functional criteria, particularly near abutment teeth with retentive attachments. Designs that leave the periodontium uncovered The base does not cover the gingiva, and the artificial teeth are prepared to fit directly upon the roots or the dowel cupping. Two types: A. Bases that are circumdentally opened, and the second, bases that are facially and proximally opened. The advantages of a base design that it does not cover the gingiva: first, prevent direct mechanical trauma, and the second, reduce plaque retention around. Third, it's possible to clean the proximal surfaces of the root cupping with interproximal brushes with the prosthesis in place. Fourth, prevents a suction effect combined with inadequate cupping shape and poor oral hygiene, which lead to hyperplastic proliferation, suction hyperplasia, and prevents undesirable vacuum retention in maxillary overdentures with retentive attachment. The second type of overdenture is the implant-supported overdenture. The denture appear like traditional prostheses, however, that part of denture overlay implant is modified to retain various attachments that receive implant extension projection above the gum. Types of implant overdenture. First, implant retained and tissue bone overdenture. It depends primarily on the residual alveolar ridge for support, and the implants will provide support in the area where they are placed. This type needs less number of implants depending on the quality and the quantity of the bone for maxilla and mandible. We can use 2 implants for the mandible and 3 to 4 implants for the maxilla. Implant retained and implant bone overdenture. It depends on implant to bear the total occlusal load. This type requires the use of sufficient number of implants to accommodate the load placed on the prosthesis, and the minimum number of implants required are 4 implants for mandible and 6 to 8 implants for the maxilla. Consideration that determine the type of implant supported overdenture: first, patient desire; second, the quality and the quantity of bone in the arch, the opposing occlusion, the amount of inter-arch distance, and economic considerations. The advantages of implant supported overdenture: first, prevent bone loss; second, maintain facial aesthetic, reduce or eliminate prosthesis movement, create reproducible centric relation occlusion, and eliminate soft tissue. 6. Improve prosthesis retention, increase occlusal force, improve prosthesis support, improve chewing efficiency, and improve speech compared with dentures. The disadvantages of implant-supported overdenture: first, some patients want implants primarily because they do not want to be able to remove the prosthesis, and this will not satisfy the psychological need of these patients to feel that the prosthesis is part of their body. Second, lack of sufficient inter-arch space makes an overdenture system more difficult to fabricate and more prone to component fatigue. And the indications of implant-supported overdenture: atrophic ridge. Therefore, objective improvement cannot be expected by fabrication of new conventional dentures, and in edentulous patients who are no longer able to wear complete dentures. The patient is basically satisfied with complete dentures but want the security of increased retention, and the patient's general health allows only a short surgical procedure. Number 2 or 4 implants are usually used to anchor an overdenture. There is an increasing tendency to place only 2 implants, especially in the mandible, due to economic consideration and general conditions of the patient. Simplification of the surgical procedure to the necessary minimum, and clinical experience indicating that 2 implants provide enough retention. The requirements of implant-supported overdenture. Requirements of implant use. First, distance between bar-connected implant must be not less than 8 to 10 millimeters, so that the length of the bar segment between implants are sufficient for proper placement of the retention clips, and arrangements of the implants should be as symmetrical as points of emergence of all implants should lie at the same height. In the mandible, 2 implants are used and could be sufficient, and in the maxilla, more than 2 implants. The removable implant supported denture may present certain advantages over fixed implant processes, such as decreased cost associated with fewer implants, easier access for oral hygiene procedure, improved facial support via denture flanges, and improved aesthetic and phonetic, particularly in the maxillary. Thank you.